ChatGerry, Role and Importance of Pulse Pressure and Mean Arterial Pressure, number 1477, VPT Sharp 038, December 24, 2025. Gerald C. EclaireMD Foundation. Category, Blood Pressure and Mortality Vascular Diseases. Preface. This article is not written as a criticism of medicine or medical professionals. Modern medicine played a critical role in my survival after multiple life-threatening events, including my recent stroke. The purpose of this article is personal. I am a patient. After my stroke, I realized that many of the most important lessons about my own survival came, not from the clinic, but from careful self-observation, long-term data collection, and reading public biomedical and physiological research. Over the past 16 years, I have collected more than 4 million personal health data points. I did not discover new biology or invent new measurements. Pulse pressure, PP, and mean arterial pressure, MAP, are well known in medical literature. Yet they are rarely explained to patients in plain language, or connected to daily decisions after major vascular events. One moment triggered this article. I discovered that my wife's annual average pulse pressure in 2025 had been consistently above 50 millimeters of mercury. This realization unsettled me, not because of a single number, but because of what it implied about long-term vascular stress. Concern for her health became a strong personal motivation to organize what I had learned. This article documents how I connected public research, my own long-term PP and MAP data, my post-stroke recovery experience, and my background in mathematics, physics, and engineering thinking. I am not proposing a treatment and I am not giving medical advice. I am describing how I learned to understand my own body more clearly, and reduce further damage. Introduction. Blood pressure is usually reduced to two numbers, systolic and diastolic pressure. These numbers are useful, but they are incomplete. They describe pressure at two moments in time, not how blood flows continuously, not how vessels behave mechanically, and not how organs are supplied between heartbeats. Pulse pressure, PP, and mean arterial pressure, MAP, describe something deeper. Pulse pressure reflects how forcefully each heartbeat strikes the vascular system. Mean arterial pressure reflects whether organs are continuously supplied with blood flow. Together, they describe vascular mechanics and flow physics, rather than isolated pressure readings. These two measures sit closer to the root causes of many mortality diseases, including cardiovascular disease, CVD, chronic kidney disease, CKD, stroke, and dementia risk. Explanation in plain English. Pulse pressure and mean arterial pressure are calculated as follows. PP is SBP, DBP. Mean arterial pressure equals systolic pressure, plus 2 times diastolic pressure divided by 3. Pulse pressure is the difference between systolic and diastolic pressure. In simple terms, it describes how hard each heartbeat hits the blood vessels. Each pulse becomes a mechanical shock that travels into small vessels in the brain, kidneys, and eyes. When pulse pressure, PP, is high, it usually means arteries are stiff and cannot cushion each heartbeat. In plain language, pulse pressure tells you how hard each heartbeat is slamming into aging vessels. Mean arterial pressure, MAP, represents the steady pressure that keeps blood flowing to organs between heartbeats. MAP is not about the hit, but about continuous supply of oxygen and nutrients to various organs. It tells you whether the brain, heart, kidneys, and nerves are receiving enough oxygen and nutrients all the time. When MAP is too low, organs are underfed. When it is too high, vessels remain under constant stress. Together, pulse pressure is the hammer, and mean arterial pressure is the water supply. You can have enough water but a dangerous hammer, or a gentle hammer, but not enough water. Both matter. Physiological meaning. Pulse pressure reflects vascular stiffness, loss of elasticity, wave reflection, calcification, and long-term mechanical aging of blood vessels. Mean arterial pressure reflects effective organ perfusion and metabolic support. PP and MP are not secondary indicators. They describe the physical condition of the vascular system itself. Why medicine rarely emphasizes PP and MAP. There is a practical limitation. No medication can reverse arterial stiffness, rebuild elastin, or remove calcification once it has formed. Drugs act on chemistry. Pulse pressure and mean arterial pressure reflect physics of vascular structure, which change slowly over decades. Clinical practice focuses on variables that respond directly to medication and fit guideline targets. PP and MAP do not. When patients ask about them, clinicians face an uncomfortable truth. These measures matter, but they cannot be directly fixed. Avoidance often replaces explanation. This is not ignorance. It is a system constraint. What medications can and cannot do. Blood pressure medications reduce acute risk. They lower peaks, reduce workload, prevent clots, and buy time. They save lives. What medications cannot do is repair aged body materials. They cannot restore vessel elasticity, undo calcification, or erase decades of mechanical fatigue. When pulse pressure rises due to stiffness, lowering pressure does not normalize vascular mechanics. At some point, further medication, only increases side effects without improving structure. My own path to stroke. My stroke followed a common pathway. Excess body weight since 1985 led to insulin resistance and type 2 diabetes since 1990. Years of chronic glucose exposure damaged the inner lining of my blood vessels, triggering long-term inflammation and calcification. As the arteries stiffened, pulse pressure gradually rose. Stronger pressure waves were transmitted into fragile brain vessels. Eventually, one of them failed in June 2025, resulting in a dangerous hemorrhagic stroke in the pontine area. Aging did not cause this. Aging amplified it. Metabolic stress over decades did the real damage. Personal data insight. After my stroke, my mean arterial pressure, MAP, remained stable around 85 mm of mercury, indicating adequate blood flow. My pulse pressure, PP, remained elevated around 45 mm of mercury, reflecting chronic vascular stiffness. Even with excellent blood pressure control, my pulse pressure, PP, did not improve. Lowering MAP further caused dizziness and fatigue without reducing PP. Biochemistry was controlled. Physical structure was not. What can still be done? You cannot reverse blood vessel stiffness. You can only manage pressure shocks. This requires stabilizing glucose, reducing visceral fat, controlling food portions, sleeping well, exercising moderately, and avoiding blood pressure spikes. It also means avoiding emotional extremes, sudden exertion, dehydration, and prolonged fight or flight states. Mean arterial pressure should remain stable, not too low and not fluctuating. This lifestyle-based approach focuses on damage control, not on repairing stiff blood vessels or already damaged organs. Conclusion: pulse pressure and mean arterial pressure reveal vascular aging more honestly than traditional blood pressure numbers alone. They explain why medications eventually reach their limits. Medicine buys time. Lifestyle and mechanical awareness preserve survival. I was not confused. I understood that I had to act early, before another blood vessel rupture occurred. Understanding pulse pressure and mean arterial pressure brought me closer to causality and replaced fear with clarity. Disclaimer: this content is provided for educational reference only, and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered or republished as your own. All intellectual property rights belong to the author, Gerald C.